Please join me in welcoming Dr. Oyedeji Ayonrinde for his talk, Don't Leave Me Behind, Navigating Cancer and Psychosis.
Imagine visiting your doctor with concerns about changes to your bowel habits, blood-stained poop, and progressive weight loss. You're examined and referred for a colonoscopy and a few other investigations. After several very anxious days, waiting for the results of the colonoscopy and biopsy, you attend the clinic with your partner. The phone message inviting you for the appointment had stressed that it was urgent and a close friend or family could accompany you. You sit in the waiting area, feeling even more anxious. This appointment feels different. The doctor invites you both into the room, and there's something distinct about the mood that makes you feel even more worried. In a somber voice, the doctor says, "I'm sorry to say, you have cancer. We'll carry out a few more investigations, a CT scan, and some blood, blah, blah, blah." The words stop having any meaning, and all you remember is the word cancer. Your partner's presence, comforting hand and reassurance, not making much impact in the moment as tears stream down your cheeks. Time stands still as many hopes, dreams, and aspirations freeze. Life flashes before your eyes in the moment. How long do you think I have to live, you ask? I can't say for certain, says the doctor. I hope we caught it early. The scan should help us gauge things. Receiving a cancer diagnosis can be traumatic. Many of us know someone who's had cancer. Some of us have lost loved ones, family, friends, or colleagues to cancer. Some of us are receiving cancer treatments or in remission from cancer. Whatever our experience, it's not a journey that we should ever walk alone. My name is Oyedeji Ayonrinde. I'm a community psychiatrist, associate professor of psychiatry and researcher at Providence Care and Queen's University in Kingston, Ontario. My program of research aims to identify and remove barriers to cancer care in the population I serve. There have been incredible advances in cancer care over the past few decades. Billions of dollars have been invested and donated and spent on cancer research and cures. 11 Nobel Awards for cancer-related research have been awarded. Queen's Health Sciences also has a globally recognized cancer research center and therapeutics program. For many cancers, early detection and treatment can change the trajectory of the illness and health outcomes. Many people find the support of friends, family, and loved ones particularly comforting through their cancer journeys. I know that far too well. I recently lost 2 family members to cancer, less than 3 years apart, and the memories are still very fresh indeed. Both my mother and brother received the best care available, supported by the limitless love of the family every single step of the way. We felt incredibly blessed to share precious moments and love for each other in our time of need. I miss them every single day. These journeys were also a turning point in my career as a psychiatrist and researcher, and I often reflect on the difficulties faced by the patients I serve. Cancer journeys can be markedly different for different members of our communities. Poverty and health awareness can have a direct impact on health choices and their outcomes. Some health conditions, such as severe mental illness, can also have an impact on every single stage of cancer care. And when I say severe mental illness, I'm referring to conditions such as schizophrenia and bipolar disorder that can be associated with psychosis, which can involve distorted and disorganized thinking, hallucinations, and odd belief systems. Up to 4% of our community members experience these disorders. My colleagues and I work with people with severe mental illness in different community settings, ranging from their homes, supported accommodation, they're unhoused in shelters, encampment tents, and yes, on the streets. On average, people with schizophrenia have between 20 to 25 years shorter life expectancy than people they attended nursery and high school with, often due to physical health conditions, including cancer. Cancer screening, treatment, and follow-up is fraught with challenges when living with schizophrenia, and sadly has a mortality rate that's 2 to 2.5 times higher than the general population for colorectal or bowel cancer. With all the advances in cancer care, does it really have to be so? No, no, no. Colorectal cancer, also referred to as bowel cancer, is the 4th most diagnosed cancer in Canada. The 2nd leading cause of death from cancer in men, and the 3rd among women. About 26 Canadians die from colorectal cancer daily. Yet it's one of the most treatable cancers with good prognosis when detected early. When colorectal cancer is caught early, 9 out of 10 people can be cured. So why are bowel cancer outcomes worse with psychotic disorders? Join me on our research journey. I'm going to tell you about Ronnie, not his true name. A man in his 50s living with schizophrenia. Ronnie is often paranoid, suspicious of the motives of others, and mumbles quietly to himself in response to hallucinations. Ronnie previously worked in a factory, but is currently unemployed and spends most of his time in a temporary shared apartment with several others. He does not exercise or cook and frequently buys fast food. Ronnie does not have a phone and occasionally uses the internet at the library. He no longer has a family doctor and has missed several routine health checks. Most bowel cancer information is available over the internet through cancer program websites, but only 14% of my patients have regular internet access. Yes, only 14%. And unfortunately, Ronnie's not one of them. Initial bowel cancer screening is often with a test known as the FIT. This test looks for tiny traces of blood in the poop, which may be caused by cancer but too small to see. For the FIT, a small sample of poop is sent to the lab for special testing. Whilst relatively straightforward for many, this is not the case for Ronnie living with a severe mental illness. The FIT is often ordered by family doctors or nurse practitioners, then mailed to the home address. However, Ronnie has no family doctor or reliable mail-in address. His sister helps him order a test. FIT test instructions about 40 sentences and require attention and concentration with each step. The picture instructions look a bit like an origami puzzle. Ronnie is often preoccupied with the taunting voices of people he does not see and has discarded several fit packages over the past 4 years. With persuasion and embarrassment, his sister helps him this time. A positive fit test often leads to a colonoscopy request. A colonoscopy is a procedure, often under anesthesia, that allows a doctor to look inside the colon through the backside using a long, flexible tube with a tiny camera. Biopsies can be taken, and little growths called polyps can also be removed. To get a clear view during colonoscopy, one needs several days of bowel preparation with laxatives and clear fluids to flush out any food residue and poop. If you've had a colonoscopy before, you know the frequent and comfortable access to a toilet is key. What if you're hungry and don't have access to regular meals? Do you miss an opportunity to eat? Ronnie shares a single toilet with the other residents, and this sometimes causes disagreements. Paranoid and suspicious with distressing hallucinations, the 25 lines of bowel prep instructions over 3 days are confusing. Ronnie believes the bowel preparation is actually a poison and ruminates about what he heard from the doctor about putting a camera inside him. Is this to secretly monitor me, Ronnie thinks? What do they mean by suspicious lesions or killing abnormal tumor cells? On the day of the colonoscopy, Ronnie is scared and refuses to give the doctor permission to carry out the procedure. He demands to leave hospital immediately and is discharged without the colonoscopy being done. 6 months later, Ronnie collapses on the street and is rushed to the emergency room where he has an urgent scan. He's confused and perplexed by the awkward sounds and uncomfortable vibrations in the claustrophobic scan tunnel. The scan finds a bowel blockage, and Ronnie requires emergency surgery to remove a large abdominal mass. Tests are carried out on the mass, and advanced bowel cancer is confirmed. Ronnie is to start on chemotherapy. Weak, exhausted, and gaunt in the hospital bed with hair loss, Ronnie is also visited by the psychiatry team who monitor his mental state and his care. He hears some people refer to him as the mental patient. Ronnie feels lonely and scared in the unfamiliar ward with no visitors or phone calls. He misses his friends in the community but has nowhere to go or call home. As he gets frailer, Ronnie's transferred from palliative care to a hospice for his final days. With severe mental illness, every single step of cancer screening and care can pose challenges that delay diagnosis, compromise treatment, and subsequently lead to worse cancer outcomes with preventable and premature death. Every community has a Ronnie. You probably went to school with him, drove past him today, or anxiously crossed the other side of the road when you saw him. Despite the great advances and discoveries in cancer care, so many community members with a severe mental illness still get left behind. We need to invest more in their support. Ronnie and friends should never be left behind in any community, and we're taking important steps to ensure they have the best cancer care support possible. My research is the Cancer and Severe Mental Illness Project, a research collaboration I started with patients, mental health, oncology, primary care clinicians, and community members in solving real-world cancer care problems. The perspectives of people with severe mental illness have often been excluded from cancer care. This is a huge gap. By reimagining cancer care through the experience of people with severe mental illness, we have identified multiple barriers that create obstacles to how, when, or if people receive cancer care. We have also engaged with health providers to understand the challenges they face. Above all, we're guided by valuable lessons learned from patients and their experiences of care. Very few can navigate the journey without assistance. By identifying individual needs, we aim to provide each patient with a unique passport. The passport is used to offer personalized and adaptable support, helping identify and facilitate care through complex assessments and treatment barriers. Patients on their journeys are accompanied, signposted, and advocated for by trained navigators to ensure person-centered care through each of the mental health and cancer care checkpoints. This includes supporting with screening, appointments, clarification of medical jargons, reassurance of safety, housing support, reducing stigma, advocacy, and yes, comfortable access to a toilet. We're developing a community of practice across Ontario and have also been involved in raising awareness across the mental health and cancer care services nationally. Perhaps with advocacy, understanding, and support, these cancer journeys can be as full of compassion, kindness, and love. The compassion, kindness, and love I recall from my own recent family experiences. None of our community members deserve to be left behind by lack of research funding, scientific advances, healthcare, or our humanity. No one. The good news is that in our individual or collective ways, we can all be cancer care navigators and advocates. I repeat, the good news is that in our individual or collective ways, we can all be cancer care navigators and advocates. Let's start today.